This patient also had another lesion just above his left eyebrow. It's a very poorly defined, slightly scaly area. For this area we chose to do a 4mm punch biopsy. We always mark the skin first and infiltrate with local anaesthetic. The punch biopsy is inserted perpendicular to the skin and gently rotated. This should be rotated sufficiently that it goes through down to subcutaneous tissue. You have to be careful of the site to make sure there's no underlying nerves or structures that could be damaged in the biopsy. The specimen is then picked up as gently as possible so that it can be slightly raised above the skin surface, and then the base of it's cut off with the scalpel. Ideally, in some of these lesions, it's good to just pick up the very small skin margin. However, many of these lesions can be quite friable. A punch biopsy was used in this case to ascertain the depth of the tumour and to confirm the histopathology of the lesion. The differential diagnosis included that of a basal cell carcinoma, a poorly differentiated squamous cell carcinoma, or an amelanotic malignant melanoma. We're just putting the suture in at this stage. Generally speaking, we use a monofilament suture. However, silk sutures would be quite adequate for a small skin biopsy such as this. The advantage of the suture is to give a good cosmetic effect, plus also it provides further hemostasis. After doing the biopsy, the area is wiped clean, and then I generally apply a small amount of betadine to the site if the patient is not allergic to iodine. This tends to minimise the post-op skin infection rate.